Before moving officially, uh, I think the music was very beautiful. It was very soothing. Whose selection was that? I don't know how many of you
Sir,
felt like
today's
that.
it was
Yeah,
actually YouTube selection, sir. I just
but it
randomly
was very, very good.
picked. Sure, sir, noted. So
I
I will
enjoyed
try
it.
to include more music like this.
Uh, so, actually, we are going to talk about non-cancer chronic pain for 3 sessions from today onwards. Um, and we know that most of us are very familiar with cancer pain, but when it comes to chronic non-cancer pain, then we should know some of the common problems that occurs in patients, and we should know what to do, when to refer. All those are very important. So today, Dr. Vineetha will walk us through the first session on chronic non-cancer pain. Uh, so Vineetha has completed her MD in anesthesia from Government Medical College, Thrissur, and then she did her postdoctoral fellowship in pain medicine from SCPGI Lucknow, and she also has a fellowship in interventional pain management from Daradia, Kolkata. She has, I think, about 1.5 years of experience in working with pain and palliative care with us, um, and her most she likes pain management, like neuropathic pain, interventional pain management, regenerative medicine, etc. So I welcome Vineetha, and it's over to you, Vineetha.
Yeah, good evening.
And
Good evening, sir.
presently, just want to, she's the consultant of pain medicine in Kim's Hospital, Anera in Trivandrum, as well as consultant pain specialist with us also. Yeah.
Yeah, good evening, sir, and good evening, everyone. And I wanted to correct you, sir. My journey with Pally Media started in 2017, not 1.5 years.
No,
So,
no, I am telling that 1.5 years you worked with us.
yes, but before also I had worked in Pally Media as a faculty. So, yeah, 1.5 years now, continuously 1.5 years as a visiting consultant. So, I hope I am audible. So, shall I share my
Yes,
screen,
yes,
sir?
yes, please.
Is the screen visible, sir?
Not, yeah, yeah, it's this one now.
The slide is visible, right?
Yes, yes.
Okay. So good evening. As sir said, there are three parts of this non-cancer chronic pain, and I don't know whether any other fellowship programs in palliative care actually includes this non-cancer chronic pain as a part of the curriculum. Uh, and but this is very important because as pain physicians or pain and palliative care physicians, many non-cancer chronic pain patients also come to us, and we cannot just tell them that you go to another specialist because we don't know how to deal with such non-cancer patients. So I would, because the first part of this topic will be back pain and neck pain, that is spinal pain, a very common problem. Second part will be neuropathic pain conditions and fibromyalgia, those kind of conditions. And the third part will be joint problems and then discussion, everything together. So I want the class to be interactive because this is very, very difficult topic. Usually when I take low back pain, I take as one class for history taking, another class for examination and management. But now I have put everything together in one class. So unless you are with me, it is very difficult to follow. So I will ask questions in between. Just, to keep the class alive, that nobody sleeps off. And otherwise, if you miss some 3-4 slides, then you may not understand the rest of the portion. But from the beginning, if you are with me, it becomes very easy as it goes. Neck and all, I don't have to discuss anything. Once we finish low back, neck pain is very easy because the same structures are there in the low back and neck. The vertebra is the same. The pain generators are the same. So, first of all, I'll ask, do you think that this non-cancer chronic pain is important in your practice? How many of you think that it is important in your practice?
Please unmute and speak.
It is important and it is difficult also.
Okay, so why do you think it is difficult? I also completely agree with you that sometimes it is even more difficult than dealing with a difficult cancer pain patient. So, why do you think it is difficult?
First of all, diagnosing it itself is becoming difficult for me.
Yeah.
And after diagnosing it, quantifying it is also difficult. Putting it under either neuropathic or nociceptive again is challenging sometimes. I think after your last class, I started using the DN4 questionnaire. It is really helping.
Okay.
It was a very helpful resource. I should be very thankful for you for that. And
Yeah,
even the small the BPI questionnaire also I started using. But many times in non-cancer pain is only difficult to handle. We think it is treated, then again they come back. I used to think we don't have much of agents to use. Relapses are common, diagnosis is uncertain, and as I told you, like psychiatric things overlapping, I really don't know whether it is the somatoform disorders as like no we discussed earlier.
Yeah.
Is it overlapping or is it is independently chronic pain which is causing the psychiatric symptoms or a psychiatric patient giving some false history?
Okay. Thank you so much for sharing your experience. And I should say that another thing is, first, the difficulties in dealing with this non-cancer chronic pain patients. Let's take the example of low back pain also. Most of the patients, not most of the patients, it may not be true for every one of you, but for in the pain and palliative practice, many patients who are coming will be from a low socioeconomic status or a middle socioeconomic status, or they may be from a good socioeconomic background, but they might have, utilized all their money already in investigations and treatment. So in that situation, if suppose if I'm taking low back pain, it is very confusing. Should I send the patient to he might have already seen many specialists. Now should I send this patient again to another specialist? Should I ask for an MRI? Should I ask for these and these blood investigations? We cannot do that right away because the patient is already in a financially very poor state. So unless we know the basics of this chronic pain management, as you said rightly, to figure out the pain generator, is there a red flag, is there an yellow flag, then only we can go ahead with the correct, we can guide the patient correctly. And another thing is, when we practice as pain and palliative physicians, even though most of the patients coming to us, maybe in many of your practice will be cancer patients, but you will in palliative also it's like that, but you will get a proportion of non-cancer patients also in your practice. Even though you focus more on cancer patients, some patients who might have already gone to all the other specialists and they are still in pain will be referred to you for further management. And so I was talking about the challenges. So as Dr. Punitha said, one problem is identifying the pain generator or what is the diagnosis. Second problem is we cannot ask for unnecessary investigations or unnecessary referrals. So we should know how to guide these patients. And the third problem is we cannot use morphine. So this is a very important problem because in cancer patients, when the pain is severe, we have a wonderful tool with us. No, we can use morphine confidently. But in non-cancer patients, the moment you give morphine, the other consultants, the patient will ask, will I become dependent? That is a problem. The dependence, addiction, all these problems are there when you use morphine in a non-cancer patients. So you are stuck there. You don't know what to do. You are completely helpless. So in all this again, and the fourth problem is, as Dr. Punita told about the psychiatric overlap, all these chronic pain patients will have some anxiety, depression. So which is the primary diagnosis? Is he a psychiatric patient with a somatoform pain disorder, or is he a pain patient? So like that, with some amount of anxiety, depression. So all this becomes difficult when you're dealing with the non-cancer chronic pain patients. So a recent survey found out that almost 20% Indian adults suffer from chronic pain. The actual estimates will be even more, because many patients, they don't go to the hospital for treatment. So this 20% maybe might be much less than what actually it is. And prevalence is even more higher in those with a cancer diagnosis, that is cancer survivors. So it is 30.8% versus 15.7% in other patients. And similar to cancer pain, the chronic pain also affects a patient's functionality, sleep, and has a huge negative impact on the quality of life. So it is very important for all of us to know the basics of this non-cancer chronic pain. The slide is not changing.
So
Slide is not changing, just a minute. Has it changed there, sir?
no.
No.
Vega, come down and maybe there is an arrow on the left hand side. Just click on that. I can't see the arrow, but there should be one.
No, I'm not seeing any. I can actually. Just a minute, sir.
Okay.
Yeah, now it's on the screen.
Yeah, it's moving.
Yeah, it is moving now. Can you see this? My pointer also on the screen, sir?
Yes, sir.
Can be seen.
Yeah.
Okay. Okay. So I'll be taking this in 3 modules as I discussed. Spinal pain, that is low back and neck. Mainly I'll be dealing with low back pain today. Neck, if I get time, I will take a little bit of that. Second class is a very important class, neuropathic pain, that is diabetic neuropathy, all the entrapment neuropathies, and fibromyalgia, myofascial pain. And the third for joint pains like knee and other joint pains and some miscellaneous pain syndromes. So coming to low back pain, so I will share one experience that I had while I was starting my, as I told, I started in 2017 with Pallium India. So I actually went to home care one day. So I saw a lady with, I think around 60-year-old with severe back pain. So we had seen that patient earlier also, not myself, not me, somebody else has seen the last home care visit. So this time the pain has increased. So at that time, all that I know was to climb up the analgesic ladder. And we as pain physicians, we are very confident in that. That is because, as I said, usually the palliative care fellowships or training programs, they don't inculcate this non-cancer pain. So and it was my mistake also. I'm not generalizing that thing. That particular moment, I didn't know, how to figure out what is a pain generator or anything. What are things I should ask and all. All that I know and I was confident was to titrate up the analgesic ladder. So at that time, a group of CCPPM trainees were there with me. And one of them had his training already completed in this non-cancer chronic pain from some other institution. So he saw me writing this, from paracetamol, I was stepping up to tramadol. Then he actually kind of scolded me, and he came and he told, "What are you doing? You are just stepping up the analgesics. You are." And he came and he asked some questions to that lady. And he did some examinations and he told me, you should send the patient urgently to a spine specialist, or urgently get an MRI done. Then I told him, patient is a very poor background, I cannot say like that directly. Then he said that it's not directly, she has some red flags, it's that you are not able to understand that. So this is my story. Even though I felt a little sad at that point of time, later on I realized that was a mistake from my side. And after that also, when I have worked with palliative care, other doctors, younger doctors, I have felt that we have a general tendency to step up the analgesic ladder. In cancer pain, we don't have to, usually the pain generator is very evident, the cause of pain is very evident. Okay, see a pancreas, the patient is having abdominal pain, the pain is originating from the pancreas. Sometimes it may be tricky, but most of the time we know why the patient is having pain. But in non-cancer pain, we don't know why the patient is having pain. So it becomes a little tricky. So I have seen that many young generation palliative care doctors, junior doctors, doing the same mistake that I did 5 years back, just stepping up the analgesic ladder without trying to find out what could be the cause. And this can actually have serious implications that we may miss this red flags. We may unnecessarily ask for MRI. The patient is already in a lot of financial problem. So that is why this low back pain class is very, very, very common problem in our population. So this is very important that you identify what is the cause. So this 2010, the study found out that this is among the top 10 diseases and injuries that account for the highest number of DALYs. DALYs means years lived with disability. So I will give two case scenarios. So these two case scenarios, sorry, before that, so what is our target with this class? Identify the pain generator. After this class, you should be able to identify the pain generator, the structure causing pain. Second, identify the pathophysiology, that is whether it is degenerative, inflammatory, like that. Third, you should identify the red flags and yellow flags. Last class I told yellow flags, I think. So do you remember what are these yellow flags? Red flags everyone know. What are yellow flags?
Anybody
I think
else
maybe
here
psychotic
remember?
malpractice.
Yeah, psychiatric and behavioral coping problems. All these come under yellow flags. Very good. Again, the screen is having some problem. Then we should know when to refer to a specialist, when to order imaging and other investigations. Okay, so with that, we go to a first case scenario. So please, all of you listen to this, and then what I am planning is, you should tell me what are the problems in this case, how it was managed, first case and second case. You can make mistakes, no problem. But after this class, again, we will come to the same case so that you will know how much you understood. So 64, this is my own patient actually, this particular case. Both the cases actually. So 64-year-old gentleman, he complains of low back pain for more than 5 years. Okay. There is no history of trauma. That means the pain spontaneously started and it gradually increased over time, because chronic pain is like that. It will gradually increase over time. It is diffuse, dull aching pain in the low back. Both sides are equally affected, right equal to left. No radiation to the lower limbs. No neuropathic features. It is purely a nociceptive pain. Then it is moderate intensity pain, around 6 to 7 out of 10. The patient says that it worsens on waking up in the morning. That is EMS is early morning stiffness. So when he wakes up in the morning, he will have severe pain in the low back with some stiffness for a few minutes, not much, maybe it's for 5-10 minutes. Then he has pain on standing for some time, but he doesn't have much problem while walking. If he comes and sits after walking and sits for some time, and again when he stands up, he has some problem. He has some problem when standing up from supine position also, but walking is relatively okay. No fever, night pain, loss of appetite, loss of weight. And last 2 years, this problem started 5 years back, but last 2 years, he's having almost similar intensity pain in the upper back and neck also. He's anxious and frustrated that his pain has not got benefited from any treatment in the last 5 years. But he runs a small business and continues to earn for his family. So what was the treatment history? 1 month after the onset of pain, he visited a spine specialist somewhere and he ordered MRI, which was within normal limits. Some degenerative changes here and there, but it was overall normal. Then he was given medications, analgesics, gabapentinoids, and advanced physio. He did some stretching exercises, a lot of physiotherapy sessions. No improvement. So he visited multiple specialists over these 5 years and taken 2 more MRIs, again within normal limits. After that, referred to multiple psychiatrists, clinical psychologists, underwent cognitive behavioral therapy and counseling sessions. Why he was referred to psychiatrist again and again? Because he was having multiple site pain with no correlative findings imaging, nothing. Imaging, there is nothing. But whatsoever, there is no improvement in pain till date. So this is a first case. Now, somebody can tell me what are the problems in the management? At least 2 problems you can pick from this. Somebody, Amrita, Punita, somebody please kindly comment. What are the problems you think? Do you think there was any problem in the management?
MRI has been taken, but basically his pain is low back pain only, but neck also he has had pain sometimes. That's what he has. So, and it is not radiating, non-radiating pain. Can be sacroiliac joint.
No, we will come to the pain generator later. We will that at the end of the class. I will ask what could be the possible pain generator. But till now, what the management has been done. Yeah, what do you think? Something was done unnecessarily. Some things were not done unnecessarily. Do you feel anything like that from this thing?
Maybe the number of MRIs.
Yeah, correct. Very good. The MRI. And just see, when it was taken 1 month after the onset of pain, as she correctly pointed out, it's a non-radiating pain. There's no radiation, no neuropathic features, no red flags, fever, night pain, loss of appetite, loss of weight. But still, after 1 month, the MRI was taken and gradually progressed over time is something that normally happens with any chronic pain. But even then, 2 more MRIs were taken. He came to my clinic with 3 MRIs in his hand. So that is one point, MRI. Second thing is, anybody else? Any other point?
I think the proper pain evaluation was not done.
Yes.
Even without any features of neuropathic pain, he was started on gabapentinoids.
Okay. Maybe that was for sensitization. We will come to that. But that is for the initial visit, there was no point in, because I have written it was 1 month after the onset of pain. So gabapentinoids was not needed at that point of time. Later on, we can say for sensitization, we can give gabapentinoids, but definitely at 1 month, not needed. Correct. Anything else? See, look at the last sentence.
Chat answers. Multiple psychiatric.
Yeah. So do you think that the clinicians, they fail to understand one very important word that I told in the last class? You know, I was telling, just now also I was telling that, I tell repeatedly, what was that? That because why he was referred to a psychiatrist, he was having pain in multiple sites, right? Why did he have pain in multiple sites? It started in the low back, but now he's having pain in the upper back, neck. What is that word which is responsible for that?
Sensitization.
Yeah, it is sensitization. No, I keep telling that again and again. So that is, but the clinicians who looked after this patient failed to understand that this is sensitization. That is why they think that he is having pain in the upper back, neck, low back, but there's nothing in the MRI. So something should be, the problem will be here. And that is why they send him to multiple, not just one psychiatrist, from one psychiatrist to another psychiatrist, from there to clinical psychologist, because their diagnosis was he was having a psychiatric problem. Of course, he will have some anxiety because he is having this problem for 5 years. But I have written that he is not, he is functional, he runs a business and he continues to earn for his family. Okay, so these 3 problems that we have discussed now, we will come to this later. And we will try to identify
Vineetha?
Yeah.
With sensitization, will the sites also be multiple
Yes.
sites also?
Yes. With central sensitization, initially see there are 2 points. One is due to sensitization. Initially the patient will have one in a very localized area, then he will have diffuse in the lower back, and then he will start having pains in the other parts of the body also. Second thing is altered dynamics. He is having some problem in the low back. Some pain generator is there, right? So when that lumbar vertebrae, the dynamics changes, it affects the cervical vertebrae also. Cervical and because all these function together. So these are the 2 reasons why the patients develop other sites pain also in the due course of time. Okay.
Thank
Yeah.
you.
So we will come to this case later. All of you should tell me what is a possible pain generator and what could have been the correct management after the class. Okay, second case. 28-year-old housewife. So this case, I saw this case in my institute where I did my pain fellowship, SGPGI Lucknow. So this 28-year-old housewife, she complains of low back pain for 2 months. No trauma, severe throbbing pain, 10/10, continuous, and worsens on any movements like turning in bed, standing from any movement, any slight movement it worsens the pain, and has significant night pain and sleep is severely affected. And she complains of mainly a midline pain, okay, and no neuropathic features, no radiation to lower limb. She has a feverish sensation on and off, but no documented high temperature. So this is actually, I'm being very honest. This is what happens. She said that when temperature has been checked, there was no fever, but she often feels on and off, that feverish sensation. No loss of appetite and loss of weight, because I didn't manipulate the history just for the case discussion sake. This is what actually the patient told. And the treatment history, she visited a specialist somewhere outside and given NSAIDs. There is no relief, not even 10% relief. And then a plain lumbosacral MRI was taken 2 weeks after the onset of pain. It was within normal limits, except for mild, end plate changes, likely degenerative. Then the WBC counts was also within normal. And she went to a pain specialist, again outside, not in our institute, who found out severe tenderness in her paraspinal muscles and did multiple trigger point injections in the paraspinal muscles. The pain worsened. There was no relief. So now tell me, what are the problems in the management? You can make any mistake, no problem. So, but kindly try to answer this. Then only the class will be interesting. Because as I said, 5 years back, I also had made the same mistake. So there is no problem in committing any mistake, but you just come up and answer. What do you think are the mistakes in this management?
Hello, ma'am. Since there is no neurological involvement, there is no meaning. I think there is no point of giving trigger point injections, maybe.
Yes, there was no need for trigger point injections, but the reason is slightly different. That I'll come to that. So yes, there was no need for indication for trigger point injections in this patient. Okay, anything else?
Rather than MRI plain, they would have taken an MRI contrast.
Yes. Why do you think?
She has throbbing pain.
Throbbing pain.
She has this throbbing pain.
So let me interrupt you, Dr. Parul. So you are telling there are some red flags in this patient, right? That is why you are asking for contrast MRI.
Yeah. We have to see the spinal cord.
Yes, so let's tell the red flags. You are very correct that there are some red flags in this patient. So please let us count it. What are the red flags that you see in this patient?
Extreme pain of throbbing nature.
Yeah, extreme pain. But one more very, very important point is not responding to conventional analgesics. Okay, simple musculoskeletal pain, it responds to NSAIDs. Sorry, my Alexa. Yeah. So, thing is that usually the musculoskeletal pain, it responds well to NSAIDs, even though we cannot give it for long. So, not responding to any of the analgesics is one actually red flag. It cannot be called a red flag because in another condition, Dr. Vineetha can tell that we discussed this last time. In another condition also, this non-response can happen, which is that not responding even if you give fentanyl. Not fibromyalgia, somatoform pain disorder, psychiatric patients. Okay. Psychiatric patients with somatoform pain disorder, even if we give the strongest opioid available, they may not get, because the pain is not the problem there. Okay, coming back to the red flags. So one is the severe pain not responding to analgesics. Second,
some feverishness, he's telling fever.
yes, very good. Feverish sensation, because every time somebody cannot come with a thermometer. So yes, feverish sensation is important. Okay, second, third.
Tenderness is there, ma'am.
Yes, tenderness. I think I didn't write that. Yes, midline pain, and midline pain and tenderness is something that we have to. I will come to that. That is there. Again, there are other red flags in this. Very important.
Sudden onset of all these things.
Not sudden onset, but you are correct. That is just 2 months. In our first case, it was 5 years pain. This is just a pain of. This is not a chronic pain. This is a subacute somewhere. 2 months. Correct. Again, something is there. Night pain. Night pain is a red flag. Okay. So night pain. So these many red flags are there. So as Dr. Parul correctly suggested, a plain MRI was taken, that too just 2 weeks after the onset of pain. So it may not change. So what are we pointing at? That showed some end-plate changes, likely degenerative. Do you think that a 28-year-old homemaker will have so much of degenerative changes in the spine? Do you think? Unlikely. 28-year-old homemaker to have degenerative changes. 60-year-old can have 40, even 40-year-old can have, but a 28-year-old. There is some disturbance. I think, Dr. Kushbu, can you please mute yourself? Yeah, thank you. So this is very unlikely to be degenerative, right? So WBC counts are normal. And trigger point injections. In the presence of a red flag, that pain specialist has gone for trigger point injections is very, very, very wrong. Because in the case of red flag, we should not touch the patient before doing any evaluation. So, Dr. Parul, because you were talking about contrast MRI, do you have any diagnosis in mind?
No, ma'am, nothing right now.
Okay. So we'll come to this later.
Spine, it can be TB spine or.
Yeah. Correct. This was actually a case of port spine. That is why WBC counts were normal. So what should have been done? Just WBC count. So what should have been done?
Differential count.
No, even differential count was normal.
Oh.
CSF?
ESR CRP. Okay. ESR CRP was elevated. Her ESR was 105 or something, but that was not done. Just looked at the WBC counts and the plain MRI, and somebody has gone for trigger point injections. So this is how the back pain is being badly managed in the periphery often. Okay, so almost the history part we have covered in these two case scenarios. Now we will go to our rest of the session, in detail. So what are the pain generators in the back? So we can see that the vertebral bodies, intervertebral disc, vertebral bodies, then the spinal nerves, and the facet joint. So how many of you know about the facet joint? So this is the facet joint, the joint that connects the two vertebrae. So we have one facet joint on each side. Okay, on each vertebrae, on each side we have, actually from one vertebrae, this is a superior articular process which goes up and forms a facet joint with the vertebra above. Then similarly, we have an inferior articular process which articulates with the vertebra below and forms another facet joint. So each vertebrae has got one facet joint above, one facet joint below, and on each side. So basically, you should know facet joint are the joints connecting the vertebrae. Okay. Then we have the sacroiliac joints. These are the sacroiliac joints. Then we have the muscles and ligaments there. Then we have it can be the referred pain from the viscera. Sometimes, the renal stone patients, they will tell back pain, right? Pain radiating from the loin to groin. So back pain can be OCA, ovary patients, pelvic malignancies, they may complain of back pain. So this can be referred pain from the viscera. So these are the possible pain generators in the back. Now, what is the commonest cause of low back pain? So in old age, more than 60 years the such patients, facet joint arthritis is the commonest cause of back pain. And when you take young adults, especially who sits for a long time, then this what is this internal disc disruption? I'll come to that. Internal disc disruption is the commonest cause of back pain. So there is a difference between internal disc disruption and disc bulge or disc herniation. So internal disc disruption means the disc, the architecture of the disc has got some changes, some nuclear degradation, some annular fissures. But when you look at the MRI, the disc may appear normal. But the internal architecture, there is some problem, and this is causing pain. And this pain is known as discogenic pain. So this is different from the radicular pain that happens in disc prolapse. So this is the commonest cause of back pain in young adults, less than 40 years, or internal disc disruption or discogenic pain. Then SA joint pain in 15 to 19%. And just look at this. Disc prolapse causing or a herniated disc causing pain is only 2 to 5%. But what do we see in the OPDs? Those patients coming with back pain, they always tell that in my MRI, there are many levels of disc bulge. There is a disc bulge in L4, L5. That is why I'm having pain. So you should tell them that after an age, maybe after say 40, 45 years or even younger, that any person, any patient will have a few 1 or 2 levels disc bulge in their MRIs. You should clearly tell them that this is not causing your pain. The chances of pain arising from a herniated disc is just 2 to 5%. The rest 95%, there is some other cause for your back pain. So that you have to guide your patients, because many patients tell that I am having disc bulge, so I will not do any job, I will not go for any, I will not do any exercise because my disc will bulge further. I am advised to take bed rest for, indefinitely. So this is wrong. There are many other causes for back pain. So these are other causes like fractures, fibromyalgia, canal stenosis, spondylolisthesis, and less than 1% cases red flags like tumor, infection. So how do you reach a diagnosis? So first you take a proper history, then the targeted clinical examination, just a minute. So then investigations and diagnostic interventions, any pain interventions, diagnostic interventions to find out the pain generator. Whenever we are in doubt, whenever we are not able to correctly get from the imaging or the clinical examination or history examination, imaging, suppose not imaging, just in even after history and clinical examination, you are not able to arrive at a pain generator, we can consider this diagnostic interventions also to find out the pain generator. So the most important part in low back pain is history taking. 70% of the cases, you can believe me, 70% of the cases, you will be able to identify the pain generator just by listening to the patient's story, that is history. Okay, examination, I won't be going into much detail. I will be just telling a few special tests that you can do. But mainly I'll be focusing on history taking, and from that every one of you will be able to identify the pain generator and guide your patients correctly. So first is the demographic history you take. So the age, generally less than 20 years and more than 50 years are considered red flags. That doesn't mean that for all patients less than 20 years and more than 50 years, you have to go for imaging. But it just means that we have to be a little careful, because less than 20 years means congenital problems, infections, and more than 50 years means malignancies, again infections. So just we have to be a little more careful. It is usually often described as red flags. Then gender, females are more prone for osteoporosis and fractures, especially in the postmenopausal phase. Then occupation. Those, some occupations, they are predisposed for developing back pain. Then we can follow, this is what I follow. If you have any other method, you can follow that also. But so we will follow the Socrates and we will try to find out the pain generator. So first we go to the site of the site. So you should ask the single most important question is the patient's pain axial pain or a midline pain, or a paramedian pain. Paramedian pain means on one side, unilateral. Or sometimes it can be bilateral paramedian, both sides, but not in the midline. So the first question is whether it is midline or paramedian. So can you tell me the structures you see in the midline? What are the structures you see in the midline?
Vertebral body and the disc.
Yeah, vertebral body and the disc. And posteriorly, we see the spinous process here and the interspinous ligaments. So all these are the midline. So any pain which is arising from the midline pain might be arising from these structures. Okay, vertebral body, disc, interspinous ligaments. Then you can see coccyx. Coccyx is a midline structure. So coccygodynia will be usually a midline pain. Now, what are the structures you see in the sides? This joint I already told. What is that?
Facet joint.
Yeah, facet joint. And what is this joint? Sacrum and the sacroiliac joint. Okay. So, and what do we have here? The muscles, right? On each side. So these muscles, this facet joint, the sacroiliac joint, all these will be causing a unilateral. Unless both sides are involved, all these will be causing a paramedian pain. Whereas, for suppose a fractured vertebrae or an infectious, a discitis, a disc is infected, So all this will be having the midline pain, similar to our port spine case. You remember the patient was having midline pain and tenderness because she was having a discitis, spondylodiscitis from TB spine. So that is it. So we'll see here the whatever I have told: disc, vertebral body, interspinous ligaments, coccygodynia. And if the patient is having bilateral, the joints, the facet and SIJ, but bilaterally involved, then the patient may complain of midline pain. Okay. But if it is unilateral, the patient will complain of paramedian pain. You can see here. Unilateral facet joint, sacroiliac joint, and the muscles, myofascial pain syndromes, all will be paramedian. So when I say site, you should always look for whether it is midline or paramedian. Okay, I think you got that. Then coming to O, what is the importance of onset? As we told in that case, was there any trauma? Was there any signs of infection like fever at the time of the onset of the pain? Is it acute or is it chronic? And was it sudden or gradual? Like in our first case, no, it started, without any trauma, it started spontaneously and gradually increased over time. Is it progressive, regressive? So all this comes under onset and duration. Then character. Character is very, very, very important in back pain. You can just divide it into nociceptive and neuropathic for simplicity. Nociceptive means aching, catching, all these are, even throbbing, all these are nociceptive. Whereas sharp shooting, burning, tingling, numbness, all these are neuropathic. So I shared this DN4 last class itself. You should use a DN4 questionnaire and you can very easily understand whether your back pain patient is having mainly a neuropathic pain or a nociceptive pain, right? Now the radiation, again, very, very, very important in back pain. So is the back pain radiating to the lower limb? If it is radiating to the lower limb, whether it is to one lower limb or both lower limbs, and if it is radiating to one lower limb, is it above knee or is it going below knee? So does anybody know what is the difference of what I am trying to point out? That above knee and below knee till the toes, below knee to the ankle or to the toes. What is that I'm pointing at? What is the importance if the patient is having a leg pain going till the toes? Anyone?
Radiculopathy.
The level of
Sciatica?
Yeah, it is radiculopathy. Okay, so we will see that the pattern of distribution in this picture. We can see how L4, L5, that you can see later when I give the presentation. But see here, this is typically the somatic pain arising from the muscles, the facet joint, the SAJ. It is typically like this. It rarely goes, sometimes it can go till here, but usually it rarely goes below the knee. So the patient will tell you, my pain is going into the lower limb. Does anybody tell you till the knee? Nobody will tell you. That you have to ask them. Then again they will tell, oh, it is going there, it is going to the limb. Then again you have to ask them, till which part it is more affected. Is it, they may say that it is going into the entire lower limb. Is it more severe, intense above the knee, or is it more severe below the knee? Most of these patients, this facet, SAJ, myofascial pain, they will tell that, yeah, the pain goes till the lower, the foot also, but it is most intense in the low back and this portion, the posterior thigh. So that is a clue. It is arising from this facet, SAG, and muscles. Whereas if it is a radicular pain, it goes like this. It follows a dermatome. This is S1. This is S1. If it is like this, it is L5, and it goes usually into the foot. Okay. If the dorsum of the foot is affected more, it is L5. If it is the sole, it is S1. So this is very important. You should differentiate whether it is a somatic pain or a radicular pain. Okay. Now, this you can, another, you can read this in detail later. But another important thing is this, look at the second point. Second point. When your patient is telling that I am having back pain that radiates into the leg, always ask which is more severe. Facet, SAJ muscles, these patients will have more back pain than the leg pain. Whereas in radicular pain, the leg pain will be more than the back pain. Okay. So this is very important. And this thing, I think you know that in the somatic pain, there won't be any paresthesia. So even if there are paresthesia, fibromyalgia patients will say I have tingling numbness, but it will be poorly defined. It will not be in a dermatomal pattern. Whereas in radicular pain, it is very prominent. The paresthesias will be very prominent and dermatomal. Okay. So the rest you can read. So this is how you differentiate between a somatic pain and a radicular pain. The most important, whether back pain, radiation to lower limb, back pain more than lower limb pain, is it going below the knee, and is it dermatomal or non-dermatomal, neuropathic features present or not. With these 5 points, you will be able to differentiate radicular pain from a somatic pain. Because if you are very clear it is not a radicular pain, why do you have to go for an MRI in the first visit itself? Even if it is 2 months duration, if there are no red flags, no radicular pain, why do you want to go for an MRI? But having said that, I will tell one thing. That is, some acute disc prolapses, initially they may present with just back pain or thigh pain. That typical radiation down into the the foot may not be there. But with some other features, severe pain that increases on walking, you will be able to find out. But that is just a word of caution. But usually this is what you see with somatic pain and radicular pain. Now, the A, Socrates A is associations, associated features. So as I told earlier, these are some of the fever, chills, night sweats, night pain, then weight loss, loss of weight, loss of appetite, then progressive neurological deficits like saddle anesthesia, bowel or bladder problems, progressive motor weakness, progressive sensory loss. All these are, red flags. Then you can ask for stiffness, because in my first case, I told that the first case scenario, the early morning stiffness was just lasting 5 to 10 minutes. But suppose if I told that the stiffness lasted 30 minutes to 1 hour, what could have been the diagnosis? What could have been the pathology?
Some arthritis.
Inflammatory arthritis. Okay, if 30 minutes to 1 hour. So again, if my patient had stiffness lasting for say 4 hours, what could have been the diagnosis? Not just 1 hour or something, 4 hours. Only by afternoon, the patient feels a little bit, relaxed. Do you know any condition in which stiffness lasts for 4 hours, 24 hours?
Systemic sclerosis?
Systemic?
Degenerative.
No. Degenerative, actually, the pain, in all degenerative conditions, the pain worsens with activity. This is early morning stiffness I'm talking about. The patient woke up in the morning. Pardon?
Ankylosing spondylosis.
Now, all the inflammatory conditions, there will be significant early morning stiffness, but that usually lasts for 30 minutes to 1 hour. That is what usually. But 4 hours and all, that kind of prolonged stiffness is seen in, it can be seen in inflammatory conditions, but not commonly. So usually 30 minutes to 1 hour, the patient will become fine. You can ask your patients with inflammatory arthritis.
Myofascial.
Yeah, and not myofascial, fibromyalgia. So fibromyalgia is a condition where patients will have stiffness for 2 to 4 hours. Okay, right. Now, neuropathic features you should ask for psychological symptoms. So you should ask for all these associated features with the pain. So this is one questionnaire we can use, PHQ-9 actually, patient health questionnaire PHQ. So this is one questionnaire you can use for assessing simply in the OPD what is a depression score. And if the up to 5 to 9, it is mild depression, you can manage. But if it is more than 10, you should send the patient to, along with your management, the patient should be sent to a psychiatrist or a psychologist for management from their side. Okay. Now, T is timing. Socrates, T is timing. So, what is the importance of time course? Again, the inflammatory pain is more in the morning. Night pain is a red flag. So, you should ask when the patient is having pain. Then, more in a particular time of the year. That is like it's fibromyalgia, inflammatory conditions. They have a tendency to worsen during the cold seasons, winter seasons. Then again, as I said, night pain can be a sign of malignancy, infection, bone pain, that is fractures, and sometimes inflammatory conditions. Then again, this is very, very important, but I don't know how much you can take from this session, but you should definitely go back and read this. This is very important while history taking. I will try to explain in simple terms. So discogenic pain. So disc is a midline structure. So whenever you are sitting, the pressure on the disc will increase. So that is why axial loading, like in prolonged sitting or flexion of the, forward flexion like this increases. So this is basically what increases and what decreases. I regularly ask this for my all back pain patients. It is not easy. Believe me, it is not easy. They will tell that my pain is continuous. Then I'll again poke and ask them what increases your pain. Is it sitting or is it standing? Because this is very important in picking out the pain generator. So if a young patient, for example, in the 40s, if he says that I'm having a midline axial pain because disc is a structure in the midline and my pain increases on sitting, I can walk, I can lie down, but my pain increases on sitting. It can be the discogenic pain. Okay. Second is facet joint. As I told, it is very common in the elderly population. Okay, so in age more than 60 years, and these patients, will have some pain while lying down because generally the facet joint, it gets loaded when the spine is extended. So whenever you are in an extension posture, like lying down, then standing or standing from sitting, standing for some time, then lateral rotation, all this causes the loading of the facet joint, and that causes a facet joint disease. Their pain actually gets relieved on walking. Okay. Again, then SA joint. SA joint also gets loaded during sitting. So this pain typically increases during sitting. Bending and riding you can forget for the time being, but classically the patient says that I can't even sit for 10 minutes or 15 minutes, but just as I get up and I start walking, I feel relieved. So this is very classical of SA joint. Also, what is the difference between discogenic pain and SA joint? Discogenic is also increases on sitting. SA joint also increases on sitting, but what is the difference? Anybody? What is the difference with respect to the site of pain? What is the difference?
It will be paramedian.
Yeah. SA joint, facet joint, all paramedian on one side, right? Usually it is affected on one side. Sometimes it can be bilateral, but still the pain will be paramedian. Whereas discogenic, disc is a midline structure. It causes midline pain, axial pain. Okay. Again, SA joint will be gluteal pain, whereas discogenic will be a low back pain. Low back and gluteal, there is a little bit of differences there. Okay. Then canal stenosis. So canal stenosis, what is actually canal stenosis? Not just of disc bulge. Canal stenosis again is a problem with the elderly. Not just disc bulge, other some problems like, facet joint hypertrophy, ligamentum flavum hypertrophy, the canal in which the spinal cord is traveling, that spinal canal becomes narrow. That is canal stenosis. And this is what you call as neurogenic claudication. The patient will not be able to walk. The patient will be very comfortable on sitting, lying down, turning in bed. Everything will be comfortable, but the patient will not be able to standing. And more than that, the patient will be able to walk. That is neurogenic. And the classical, this is very classical, on leaning forward or on flexion, the pain will come down. That is why these patients usually use a stooping gait. This is also known as shopping cart sign, because you travel when you are carrying a shopping cart, you tend to bend like this. So these patients are very comfortable in that posture. Then iliopsoas trigger point. Iliopsoas and quadratus lumborum are deep muscles in the back. So iliopsoas, you can read this later, standing from a deep seated. But this is very important. Why? Quadratus lumborum, this muscle, the myofascial pain presents as flank pain. So many patients, they undergo ultrasound because it is being mistaken as renal disease. So quadratus lumborum pain, this myofascial pain presents as flank pain, and this is an accessory muscle for respiration. So they will say that coughing and sneezing increases my pain. And also this is very classical. The turning over in bed causes pain. So that is how we diagnose this quadratus lumborum. In supine position, they are comfortable. So you can go back. I know it will be very difficult to take all these from this point of at this point, but you should go back and you should utilize this in your everyday practice. Always ask the patient what increases and decreases your pain. So this I have already told, and you can go, you read this later. What is the difference between neurogenic claudication and vascular claudication? In simple terms, neurogenic claudication patients, that is lumbar canal stenosis, these patients, first of all, along with pain, not in the early stages, but in the late stages, they will have numbness, tingling, paresthesias, neuropathic features. And second thing is, both in these situations, the pain increases on walking. But in vascular claudication, the pain decreases immediately as you stand, as you stop walking. Okay. Whereas in neurogenic claudication, the pain will not decrease when you stand. You have to sit down. You have to sit down for a few minutes for the pain to completely come down. So this is very important, because if you don't know that, you will send the patient for an unnecessary Doppler. Because the peripheral vessels, there will be some atherosclerotic changes. The pulses may not be always very much palpable. So these are the simple things in which from history you will understand whether it is a neurogenic claudication or a vascular claudication. And again, you can ask the patient on flexion, on bending forwards, is your pain decreasing? That is very classical of neurogenic, whereas vascular, there is no change on bending forwards, so flexion. Okay. Now in the in the last part of Socrates, that is severity, you should always record in your documentation what is the pain score. And severe pain not responding to analgesics is a red flag. You won't know that unless you document your pain scores. And then you should ask the treatment history, like what are the drugs, interventions, physiotherapy, all those things which the patient had undergone in the past. Then the past history for systemic diseases like diabetic hypertension, all those things. Then in the, red flags, because yesterday only I had a patient, a CA prostate patient who has 8 months history of back pain. So that patient had developed 8 months history of back pain. And in my first visit, this patient told that MRI already done, there is no meds, nothing. But the patient has severe back pain, and this history of malignancy is a red flag. So I was a little bit, doubtful whether to go ahead with an intervention, but the patient was in severe pain, and the recent MRI showed there are no meds. So what I did is I have to give him a facet joint diagnostic block, but today I was informed that the patient did not have any relief. So the patient, I asked them to get a PET CT done because MRI may not pick small malignancies. But again, since the patient, I ruled out infections, ESR, CRP, so there is no problem in trying a diagnostic block. Now I can, because imaging is normal, facet joint arthritis, you will not pick up from the imaging. Imaging will be normal. So only with the diagnostic block, you will be able to know whether it is a facet joint problem. So I gave a diagnostic that is also negative. So now I can ask him for a PET CT. That is how we can grade the patients correctly. So known malignancy, immunocompromised, IV drug abuse, these patients are prone for spondylodiscitis. So all these are red flags. Then you can ask the family history of any chronic pain syndromes, inflammatory conditions, fibromyalgia, all these things runs in the families. So that is about the past history. Then the personal history, menstrual history, postmenopausal females are more common for, osteoporosis. So all these points you can ask in the personal history. So the red flags, I have already told all the red flags, less than 20 years, more than 50 years, acute and subacute pain. Remember my case scenario 2, duration less than 3 months. When there is a history of trauma, you may be dealing with a fracture. Then constitutional symptoms like fever, chills, night sweats, weight loss, unrelenting pain, not relieved by rest and analgesics. Then progressive neurological deficits and also night pain. I think I have not mentioned in that. So these are the red flags. Then these are the yellow flags. The psychosocial factors, like it is not actually a clinical depression what we are talking about when we are telling yellow flags. Clinical depression comes in orange flag. Okay, these yellow flags are a negative attitude towards back pain. The pain, whatever pain it is, pain is harmful. If I do any activity, the pain will increase. So I won't improve my functionality. Even if I get relief from my medications, I won't improve my functionality, because if I function more, my pain will increase. These negative coping strategies, fear avoidance behavior, excessive stress. So all these comes under yellow flags. So our agenda is to rule out the red flags immediately and to address the yellow flags early. So before we go on to this examination part, so any doubts you have regarding history, you can ask now. And also I will request Sripriya to do 2 or 3 poll questions also.
Sure, ma'am.
Yeah.
So
Any doubts on the history you can ask. This midline pain, paramedian pain, sitting, walking, it will be a little bit confusing. But if you have any doubt, I can clear it now before we go on to the because this history is a main thing. Examination, I will be just touching only some special tests you can perform in your OPD, nothing more. So in 70% of cases, you will identify the pain generator from the history. So if you have any doubts, you can ask now.
Anybody?
Okay, poll questions. Quadratus lumborum can occur with people who use certain postures, like abnormal postures during your routine work. And another, in my practice, what I have seen is secondary or after any other problem in the vertebrae. That is, suppose you have a intervertebral disc prolapse. After some time, say 6 months or 1 year, that disc has desiccated, dehydrated. There is no disc prolapse now. But due to the altered biomechanics, this muscles will go into constant spasm or a constant pathology. So I had one patient with vertebral fracture. So this patient was posted for vertebroplasty because it is a vertebral fracture and had severe back pain. So this patient was posted for vertebroplasty, but this patient, 78-year-old, vertebroplasty is cementation inside the vertebral body. So this patient did not want to undergo such an invasive procedure. So he came to the pain clinic asking for morphine. You give me some strong analgesics. I am having such severe pain. So vertebral fracture should cause a midline pain, right? The vertebra is in the midline, but this patient was having flank pain. And when I examined, he was having trigger points in the quadratus lumborum. So I gave him quadratus lumborum myofascial, trigger point injection, and the patient got around 70 to 80% relief. So whenever there is altered biomechanics, it can be due to fracture, it can be due to intervertebral disc prolapse, or it can be due to abnormal posture. Whenever there is altered biomechanics, then this can happen. The muscles can go into constant strain, spasm, and can result in myofascial pain syndrome. So is our poll over? Yeah, you can continue.
Spondylolisthesis can also cause.
Yes. Listhesis. Again, that is one situation where there is spondylolisthesis, spondylolysis. All these are basically situations in which there is altered biomechanics. So any situation in which there is, the biomechanics of the lumbar vertebrae is altered, the patient can have a secondary myofascial pain syndrome. Here, muscle is not the primary pathology. This is a secondary myofascial pain syndrome. But that is causing the patient pain, not the fracture, not the disc. So if you go and give a transforaminal epidural injection for the disc pain or a cementation in a vertebroplasty, you are actually doing an unnecessary intervention. So our poll is over.
Yes, ma'am.
Priya?
Yes, ma'am. So we had 17 responses coming in.
Yes.
So you would like to publish the results?
Yes. The first question. So I think I clearly mentioned it. What is the cause in in less than 40 years, young adults? Commonest cause of low back pain is
Disc disease.
yes, internal disc disruption or discogenic pain. 35% majority have told that it is internal disc disruption, so that is good. And second question, I'm very happy. 3 to 4 hours of stiffness. 71% have correctly pointed it as fibromyalgia. Inflammatory arthropathy, 29% have written it as inflammatory arthropathy, but it usually produces 30 minutes to 1 hour or maximum 2 hours. 3 to 4 hours of stiffness is usually seen with fibromyalgia. Okay. So how to exit this poll, Sri Priya?
I have closed it from my end, ma'am. So
Okay. Thank you. So in the next 15 minutes or so, I will complete the examination and the rest of this. I think by 8:30, 8:40, we will finish, and after that 20 minutes is for discussion. So now you know a little bit about the pain generators in the spine, the history taking. So we will see examination part. Not moving again. Yes, can you see the slide?
Yes, ma'am.
Okay. So there are 3 headings: general examination, musculoskeletal, and neurological examination. All these 3 are equally important, but I will be focusing on this thing, special test. Okay, a few special tests to identify the pain generator, and we'll keep it on inspection and palpation. These 2, forgive me, I won't be going that much in detail because we all know the sensory motor. We have studied during our MBBS period or this thing. So musculoskeletal, I'll directly go to musculo. This general examination is very important because some red flags like pallor, edema, and weight loss. The person is emaciated. Then temperature, fever, all this you can pick from general examination because you already know that. I'm not going into that. General examination, your aim is to address any red flags, to find out any red flags. Now coming to musculoskeletal, we will inspection, palpation, and some special tests. So inspect for the posture, whether when hearing this topic also, how many of you are sitting in the correct posture? If you take a poll, I think out of 30, maybe 2 or 3 might be sitting in the correct posture, I guess so, including me. So, I mean, I'm also not in a very correct posture now. So posture, look at the posture, the patient, how the patient is sitting, alignment, any kyphosis, lordosis, scoliosis, range of motion. You can inspect, the patient, to ask the patient to flex and extend and see how much the patient is able to move. Inspect that. Then gait. Sometimes the L5 radiculopathy patients will have a Trendelenburg type of gait. The foot drop patients will have a stepping gait. Then muscular dystrophy, that patients will have a waddling gait, and osteoarthritis patients will have an antalgic gait. So look at the gait also. Then heel walking and toe walking may not be very important at this stage, but as you practice more, you can try this, because ask the patient, anyway you are asking him to walk. Now after he has walked like normally how he walks, ask him to walk on the heel. So heel walking, if he is able to walk, if he is not able to walk on the heels, that is suggestive of an L5 root problem. And if he is not able to walk on the toes, he is comfortably walking on the heels, but he is not able to walk on the toes, it may be, it suggests a S1 radiculopathy or an S1 nerve problem. Okay. Then coming to palpation, you have to palpate the spine. So remember my 28-year-old lady in my second case scenario, midline tenderness, except in fibromyalgia or somatoform pain disorders, usually midline tenderness suggests something, a kind of a red flag, fracture, infection. Okay, not always, but you have to be a little bit more careful if it is midline pain and tenderness. But fibromyalgia patients will have pain everywhere. Somatoform pain disorder also, there will be pain in the midline. So interpret whatever I am telling, accordingly. But generally, midline tenderness is something we have to be careful about. Then paraspinous tenderness is more innocuous, more innocent. It is, facet, myofascial, sacroiliac, all these are paraspinous tenderness. Then you examine the muscles. Okay, so these are the Vineetha was asking me earlier, the muscle spasm, is it just iliopsoas and quadratus? There are so many other muscles. There's erector spinae group, that is lumbar paraspinous musculature, iliopsoas, quadratus lumborum, the gluteal muscles like gluteus maximus, minimus, medius. Then piriformis, very important muscle. The symptoms mimic what? Piriformis syndrome, anybody knows? The symptoms mimic what? Just because in case if you are sleeping.
Sciatica.
Yeah, sciatica, very
Sciatica.
good. Yeah, very correct. It mimics sciatica. Okay. Now, so this is how we have to palpate for the paraspinal muscles. That the differences for erector spinae, that is superficial muscles, you have to just gently palpate. And for iliopsoas also comes in this same location. Okay, first picture. But you have to do a deep palpation against the spine. So that is how you understand whether it is superficial or the deep iliopsoas. And gluteal muscles, this is how you palpate for the gluteal muscles. So this is how iliopsoas palpate deep against the spine. And this is how the iliopsoas patients usually present. Okay, vertically. They will, when you ask the how is the pain, they will show like this. They will run their hand like this. Okay, and so that is what. And passive extension of hip, that is when you do ask the patient to lie prone and you extend the leg, extend the lower limb, you raise the lower limb, that is extension of the hip, the patient will have pain. That is suggestive of iliopsoas. So don't worry too much about iliopsoas now. But quadratus lumborum you need to know, because I have seen so many patients being sent for unnecessary investigation. This is typically the gem sign. The gem sign is just you palpate the flank, the patients will jump. There will be severe pain. So that is suggestive of quadratus lumborum, myofascial pain. Okay. Then SI joint, you know where to palpate for the SI joint. Most of you know where the SI joint is, that dimple, PSIS. Okay. Then facetious, this is actually thoracic spine, but in the area shown is correct, very close to the midline, maybe like within 1 to 2 centimeters from the midline, the paraspinal tenderness that corresponds to the facet. Okay, but many patients with facet will not have tenderness. It is very, very difficult to diagnose facet clinically. Only a diagnostic block will help. Okay, then as I told, I will be focusing on this part, some special test. Okay. So there are 5 headings. One is the test to confirm nerve root irritation or radicular pain, SI joint, facet, piriformis, and range of motion. And I will not be discussing all the tests. If I discuss all the tests, everything will go above your head. I'll be just telling one or two, and you can, interested people, you can read further. Okay. But it is important that you should know this, because then only your diagnosis part will be correct. So I think SLR everyone knows, but what is more important is this part. So radicular pain, a patient with a disc herniation, ask the patient to lie supine, then you should lift the limb. That is a passive thing. Don't ask the patient to raise the lower leg, okay? Lower limb. You have to, it's a very common mistake that you will ask the patient to raise the limb. Ideally, you have to take the hold of the patient's leg and lift it slowly, 10 degree, 20 degree, 30 degree. So in this angle, that is between 30 to 70 degree, if the patient is having pain, that is suggestive of radicular pain. Okay. So what if the patient is having pain in this part, less than 30 degree? Just as you lift the lower limb, 10 degree, 20 degree, the patient is complaining of pain. What can be the cause?
SIJ, sacroiliac joint pain.
Yeah, SIJ is one possibility. Anything else? More commonly?
Myofascial pain.
Yeah, correct. It is muscular. Okay, usually
Muscular,
less than 30 degree means it is muscular. 30 to 70 degree is radicular. And pardon? Yeah, after 70 degree, sometimes at 80 degree, 90 degree, the patient is having pain. That may be again muscular, hamstring stretching or something. And you have to also ask where the patient is feeling pain. Ideally, there should be reproduction of the radicular symptoms. The pain should be radiating down the leg. Okay, but I'll tell you, it is not very common to get a typical SLR positive in all patients with disc prolapse, but it helps in our diagnosis. Okay, you have to, just because SLR is negative, don't tell the patient is not having radicular pain. You have to take everything together, the history, what exacerbates the pain, then take SLR also. Don't just go alone with the SLR, okay? Especially in chronic radiculopathy, many times SLR will be negative. Okay. Now, this is very important. I don't know how many of you are still with me in this at this point of time, but those who are listening, those who feel that this is too much, just ignore it. No problem. This is not that important. But those who are actually getting these kind of patients, then you should know this Bragard's sign. Okay. What is Bragard's sign is? You lift the patient just like doing SLR. The patient is having pain at 50 degree, okay, or say 60 degree. You bring it back to 50 degree. Ask the patient, are you having pain now? The patient will say, no, it was there earlier when you lifted more, but now it is not there. At this point of time, you dorsiflex the angle, again the patient will have pain. I use this regularly, and this is more sensitive than Bragard, this SLR. And another thing which is very sensitive is closed SLR. But this is very rare. In extruded disc or sequestrated disc, you will get this. But if you get this, this has a specificity of 88%. That is 90%, you can be sure that you are dealing with a disc herniation or radicular pain. That is, this is the problematic side. The patient is having pain in the left side. But when you are lifting the right side, the patient is having reproduction of symptoms or pain in the opposite side, that is contralateral side. This closed SLR also you can see. Okay. Now this I'll not discuss now. There are slump test or sitting SLR. Then femoral stretch. See, the other SLR, what I told you, the classical SLR is for L4, L5, S1. If the nerve root involved is L2, L3, it is rare, no? The disc herniation, that level is rare. But if it is L2, L3, SLR may be negative. But when you ask the patient to lie prone, flex the knee like this, flex the knee, hold the patient's leg, and then you raise it, lift it. The patient is in a prone position and you are lifting the limb. This is femoral stretch test. That will be, the patient will develop excruciating pain. So along with SLR, you should do ideally a femoral stretch test also. Okay. Then sacroiliac joint, these three are the important tests, but I will restrict myself to Faber. The classical Faber test: flexion, abduction, and external rotation. Okay. Humans, you can read later. Actually, this is a more specific test, but you can read later. Okay, Faber. So Faber, how do you do a Faber? Ask the patient to lie supine. Then ask the patient to the affected side. This is the affected side. Ask the patient to flex the knee and keep the foot on the opposite knee. Okay, this position. You have to stabilize the pelvis using one hand, and using the other hand, you give a force, downward force on this affected side. Okay, so that will cause flexion because already it is in a flex, hip is flexed, abduction and external rotation. So that will strain the SI joint and the patient will have pain on the affected side. So I often do Faber as a first test and then go to the other test. So you should be knowing how to do a Faber. If you don't know any other test, this is very easy to do. And see, believe me, patients are typical SI joint pain. You don't have to do anything. You ask them to keep the leg like this, they won't be able to keep it like that. Just when they start to keep like that, they will tell that I'm having pain in my gluteal region. You don't have to do anything actually. Okay, so that is SIJ. Now coming to facet. Facet you should know because I told more than 60 years, this is the most common cause of pain, back pain. So for facet, what you have to do is ask the patient to extend, not flexion, just extension like this, and then lateral rotation. Many patients may not be able to do this lateral rotation, but you can at least ask them to do the extension. So again, believe me, the facet patients will, just as they try to extend, they will catch hold of the low back. Okay. So, but again, clinical findings, we cannot confirm the facet joint just because this extension is was not painful. We have to again go for a diagnostic medial branch block for facet. But this is the only one clinical test. This paraspinal tenderness and the facet maneuver is how you can get some idea regarding the facet joint pain. And piriformis. Piriformis is also very important because you can avoid an unnecessary MRI. So this is a piriformis muscle. You can see my pointer, right? So this muscle comes from the pelvis, and it comes out through the greater sciatic notch and attaches to the greater trochanter femur. So it is a gluteal muscle. So these patients will have a deep gluteal trigger point. Why I'm telling deep gluteal? Many patients with back pain will have gluteal myofascial pain, but that will be superficial. Just when you take the gluteal muscle like this, the patient will have pain. But this you have to press. Can you see my thumb? Can you see my thumb?
Yes, yes.
Yes. So you have to press like this, deep in the gluteal region. Then only you will get the piriformis. But if it is just gluteal myofascial, you take the gluteal muscles like this, there will be pain. You don't have to press deep. Okay. So it is a deep trigger point, piriformis. And this is one sign. I have not seen honestly many patients, but textbook says this, that piriformis syndrome patients, they will have a the ipsilateral leg, the affected leg will be externally rotated in the supine position. Okay, then forget pace. This is what I usually do. Fair, that is flexion, adduction, internal rotation. I do it in the supine position. You can do in the lateral position also. Ask the patient to flex the hip, flex the knee, little bit of flexion at the hip and knee, and then apply a downward force. So you are doing flexion at the hip plus adduction and internal rotation. Okay. So that will be positive for piriformis. That will reproduce the symptoms. Patient will have severe pain at that point of time. That is piriformis test. Okay. Modified Chobos, I will not, this is for ankylosing spondylitis for looking at the range of motion. I think I have given in the module also. You can read, interested candidates can read that. So now coming to neurological examination, this is very important when you are if you are having low back pain patients, this is very important. But since we have all studied this during our MBBS curriculum, I am not going in detail, but just I'll brush through that. You should know your dermatomes, okay? Which dermatome, and then only you will understand whether the patient is having a dermatomal pain or a non-dermatomal pain. Then you should see whether the patient is having a sensory loss, that is numbness. Patient will say numbness, tingling, but you should look for sensory loss as well as hyperalgesia, allodynia. and you can go through this later, that each radiculopathy, how will that present? L4, how will it present? L5, lateral, posterolateral, and S1 typically posterior. This is how. So numbness, which part they will have numbness? And I told L5, usually this part and the dorsum of foot out also, but the lateral aspect of foot and sole will be affected in S1. So that way you can differentiate. Now, you have to look for at knee, ankle, hip, big toe. You have to look for the motor aspect, bulk, tone, and the power. Then grading of power, that should be done from 0 to 5. See, one thing I will tell you, whenever you are dealing with such patients, at least in certain hospitals, medico-legal problems, medico-legal issues can be there. So you have to document that when you saw the patient, the power was 5/5, because otherwise 2 months back the patient will come and say, and I am unable to walk, the power is 2/5, 3/5. Why didn't you send me for an MRI earlier? Or why didn't you refer me to a specialist? Some medical legal issues can come up, right? So that is why documentation is very important. You document that. I always document, even though I may not write the exact power 4/5, 3/5, but I always document there is no sensory loss, no motor weakness in all my back pain patients. That documentation is very important. Okay. Then again, the reflex also, I always write the patient's reflexes are normal. Even if you are in a hurry, you know that the patient is not having radicular pain, there are no red flags, but still you have to document the sensory, motor, and the reflexes. Okay. If you have time, definitely go and check all the reflexes. Okay, grading, you may or may not write the grading, but you should definitely write whether it is normal, diminished, or exacerbated. Okay. Now, this is just a revision of whatever we have learned till now, because I know most of you will be very confused hearing all these new terms like internal disruption, facetogenic, facetoarthritis, and all those things. So this is a few slides are just a revision. So try to be with me. I will be asking questions. And neck pain, last 5 minutes, I will just say 2 slides. But this is I can say the last part of my presentation, the revision and the management. Okay, I'll be telling you a little bit about the management part. So pain generator, what is this? Discogenic pain. You know, what is this? What is this?
Cassette.
Yeah. So unless you are answering, I'm not going, I will not go ahead. Okay. So this is facetogenic. There is no problem if you are, if you are mistaken, but you should tell. Okay, next. What is this?
Sacroiliac.
What is this?
Something
is pressing on the nerve. Pardon?
Disc prolapse.
Yeah, disc prolapse. Very good. Disc herniation. Next, what is this? Okay, this you will not be able to get from the picture. What I tried to show was canal stenosis. Okay, because central canal you will not see in this picture. Right. What is this?
Muscle, paraspinal muscle.
Paraspinal muscles. Very good, very good. So remember, whenever you are having back pain patient, the pain generators are going to be one of this. Okay, nothing outside that. That is very, very rare. Okay. Now, so let's go to the next thing. Management. This one slide about management and interventions I will tell in the corresponding slides. See, there is no role for any routine investigations or routine imaging in back pain. This should be guided by clinical suspicion. I had a neck pain, 32-year-old neck pain patient, duration 5 years and 5 MRIs with him. Okay. So don't unnecessarily go for MRIs or, blood investigations or imaging. Second thing is, you identify the red flags. If there are red flags, then go for urgent blood investigations and imaging, also referral to a spine surgeon, neurologist, or whoever. Always give a short course analgesics, because I believe that helps in desensitization or preventing the peripheral and central sensitization. Always you can give a 5 to 7 days short course of NSAIDs if not contraindicated. If contraindicated, Ultracet or paracetamol. Then this is what Amrita talked in the beginning, what was the role of gabapentinoids? See, in 1 month, there was no rule, but if the patient is coming to you, my first case scenario, patient is coming to with 5 years duration of pain. Earlier, the pain was localized to low back, but now it is diffuse low back pain along with neck pain, that kind of, sensitization. Whenever there is sensitization, not that I give, you can give anything, gabapentinoids, TCAs, or SNRIs like duloxetine, amitriptyline for desensitization. Okay. And also, if there is neuropathic pain, you have to give these drugs. Then always put them on a structured physiotherapy program, refer them to a physiotherapist. Start from the day one. If the patient is severe pain, give them 5 days course of analgesics, and then ask them to start. Initially, they should be doing stretching, and after 1 month or a few weeks of stretching, then they can go on with strengthening. But initially, it should be stretching exercises. Then we come to interventions. That is, there is role for diagnostic interventions. Like I think I told multiple times, facet you can diagnose only through an intervention, and there are therapeutic interventions also for pain relief. If nothing else works, the patient is having pain for more than 3 months, you have tried analgesics, you have tried physiotherapy, there is no indication for surgery, the patient is still in very much pain, you can refer to an interventional pain specialist for interventions. So the next slide is, so as I told, this is a revision. Okay. So facet arthropathy, what is the age group in which it is affected? Quickly.
Elderly.
Elderly, very good. Yeah. So this is a facet joint. What will be the kind of pain? So this is, don't mistake it as bilateral. This is just showing the reference pattern. But what is important is the radiation till
Knee.
knee. Okay.
Above the knee.
And it worsens on standing from sitting, standing
Extension.
extension, anything in which you are extended posture. Patients will be usually initially comfortable on walking, but later on they can say that walking also causes pain, but initially they will be comfortable on walking. Then what is the intervention that we do? Medial branch of dorsal ramus block, initially a diagnostic block, and then we do a radiofrequency ablation under CM guidance. Okay. So that is the only way to diagnose and treat facet joint pain. Second, internal disc disruption. What is the age group?
Less than 40.
Yeah, less than 40 years. So this is what happens in internal disc disruption. This is a normal disc, but this disc, it looks swollen, right? Actually, what is happening is this nuclear matrix degradation, annular fissures developing in the annulus fibrosis. Patient will have pain on what kind of pain? Midline, paramedian?
Midline.
Yeah, midline, axial pain, and the pain increases on
Sitting.
sitting.
Standing.
Yes, why? Because the disc is loaded while when you are sitting. So sitting and forward flexion increases the pain. Okay, and the good thing is IDD is self-limiting. Don't go for an unnecessary MRI. Yeah, if for some patients, if it lasts more than 6 months, there are treatment options like Ramme communicants blocks, ozone treatment, bioculoplasty, so many interventions. But I have not done a single intervention for IDD, dyspogenic pain. It is self-limiting. Give them, analgesics and physiotherapy. The patients will improve. That is the importance of diagnosis. Otherwise, you will go for an unnecessary all the other things, investigations and interventions also. Now, SA joint. SA joint you can get in old age, young age, inflammatory. The patients with inflammatory arthritis, rheumatoid, SLE, all these patients, ankylosing spondylitis, all these patients are more prone to developing SA joint. What is the type of pain? What is the type of pain?
In the gluteal region.
Yes, gluteal pain that radiates down the thigh till
up to the knee only.
Yeah, up to the knee usually. Okay. And worsens on sitting.
Sitting.
Yeah, sitting. Usually these patients, this is facet, patients can say that there is pain on walking also, but SAJ is very classical. They will say that once I start working, I am very comfortable. I can work for a long time. But in very advanced cases, they can say that I can walk in the normal pace, but if I increase my pace, walking fast, my pain will increase. So that can happen in SAJ in advanced case, but usually classically the history is that I am very comfortable while walking. Okay, so this is what we do for SAJ, intra-articular steroids or cooled radiofrequency ablation. But SAJ also, I do intervention only if the patient does not have relief with medications and physiotherapy. Because why? SAJ intra-articular steroids, any joint you put the steroid, the effect is going to be short term. Sometimes 3 months or less than 3 months. So we sometimes the patients, as I told you, SAJ, sacroiliac, they won't be able to do the stretching, because when they try to bring the knee chest position, raise the limb, bring it close to the chest, they will have severe pain. So they won't be able to do the exercises. Only in such patients I go for intervention. Otherwise, SAJ, there is very good response with medications and physiotherapy. Then lumbar radiculopathy. So what is the kind of pain in radiculopathy?
Unilateral.
Shooting, sharp shooting pain.
Yeah, paramedian pain, unilateral paramedian pain that goes till the beyond the knee, to the ankle or to the toes. And very important, what will be there? What will be the character of pain?
Shooting.
Yeah, shooting. Along with that?
Along with dermatome level.
Dermatomal. Okay, along with that, what else the patient will complain of?
Paresthesia.
Yeah, very important. Paresthesias, numbness, tingling. And classically it worsens on?
Walking.
The patient will be very comfortable sitting, lying down, but standing and more importantly, walking, the pain will worsen. Paresthesias will also worsen. So what we do for disc herniation, especially in the acute stages, the first 6 months or 1 year, this transforaminal epidural injection is very effective. I hope there are no spine surgeons in this class. So you can actually avoid a surgery in the first 6 months or acute cases. So I actually forgot to include that picture. 3 days back I did a case. So my husband is a neurosurgeon. So I showed him that disc herniation. He told that you should urgently refer the patient to a spine specialist, because it was a very big herniation. And I told the patient also, but the patient has already consulted the spine surgeon. The patient has some financial constraints, so she is not unable to do but the surgery now. But she's in intractable pain, bed bound, I can say. But the good thing is she came to me within 3 months of her onset of pain. So I thought that I should include that picture here. This is of another patient. She got excellent response. Okay, I did the case last week, and yesterday after 1 week follow-up, she has got excellent response. She is walking. Otherwise, she was bedbound. But again, I don't say that that is a correct thing, because with big hurt, you should always counsel the patient. If she develops any red flags, in case of red flags, even if the pain is severe, don't go for any intervention. But my patient did not have any red flags. It was a big disc, but there was no red flags, like, no numbness. I mean, no sensory loss. There will be some subjective numbness, tingling, but no sensory loss. I actually looked in that patient all the, I documented the grading, the power at the hip, knee, ankle, because I know this patient can cause trouble to me. So I documented the power, I documented the reflexes. There were no red flags. I took up for transforaminal epidural. The patient is doing very well. So that is very important. But in chronic cases like 5 years, 10 years, the result with the epidural may not be very encouraging all the time. Okay. Lumbar canal stenosis, what is the age group? The grandpa is again here. Yeah, elderly patient. So I told what is happening and what is the kind of pain. It is usually bilateral.
Okay, bilateral.
It is bilateral. Usually it is bilateral. That is the difference between radiculopathy and neurogenic claudication. This is usually bilateral, and the patient, at least in the initial stages, will complain more pain here in the thigh and the buttocks, not in the toes, not in the lower leg. The patient will say that the moment I start walking, there is a kind of tightness, stiffness. In Malayalam, they say pidittam, tightness, numbness in the buttocks and thigh region. Okay, I'm not able to walk further. But in advanced cases, there will be radiation to the till the foot. There will be neuropathic features like numbness, tingling, paresthesias. But initially, that may not be there. This will be the presentation initially. Then these patients will have classically the reduction of pain on
Bending.
yeah, bending. Forward flexion reduces the pain. And what do we do for that? Actually, the result is not very, the patient may not get long-term relief, but for symptom, actually, you can ask the patient to get a spine surgery consultation and spine surgery if the patient is severely symptomatic. But for stenosis, they do fusion. So fusion itself can have a lot of problems. So if the patient is willing for surgery and financially affordable patient, you can definitely send, because that will give long-term pain relief. But suppose the patient says, I can't go for a surgery now. We do caudal epidural steroids and caudal neuroplasty. So this caudal steroids is nothing but it's epidural steroids only, but we are giving through the caudal route. Anesthetists are very familiar with this caudal route. We give for surgeries also in pediatrics. So this caudal epidural, they will get relief for like 3 to 6 months, but they will have to repeat it because stenosis is not something you can reverse. No, it is a permanent thing. So after 3 months or 4 months, sometimes after 6 months, the pain will come again. So I have patients, poor patients who cannot afford a spine surgery. I do them every 3-4 months in a small dose of steroids. I do them the same procedure every 3-4 months, but they can do all their routine activities in these 3 months time. The only problem is the pain will come again. Okay. Now last one is myofascial pain. How will be the myofascial pain presentation usually? Is it unilateral? It is midline or paramedian?
Unilateral. Paramedian.
Yes, it is paramedian. What will be the nature? It is an aching kind of pain or a sharp shooting with neuropathic features?
Aching.
Aching kind of pain. And what will be the radiation? Radiation of pain?
No radiation.
Or there may be some radiation, but it will not go below the knees.
Below the knee.
You can see there will be radiation. This is iliopsoas actually. So there will be some radiation, but definitely will not go beyond usually will not go beyond the knees.
And that SLR we can see.
Yeah, SLR also will be negative. And then this is quadratus lumborum flank pain. So turning in bed, I told, if your patient says that my pain increases on coughing, sneezing, remember quadratus lumborum may be the culprit. Okay. All patients may not classically say flank. Some patients will have gluteal pain, this region. But that is when the history becomes important. The worsens on turning in bed, coughing, sneezing, etc. Okay. So for this, what I do is, actually, I think this is that patient I told you, this picture is of that patient, which I told you earlier, vertebroplasty. The patient was posted for simulation. But I did a QL for that patient. So ultrasound gated, you can give the quadratus lumborum. Anesthetists may be already aware of this quadratus lumborum blocks. They are giving it for postoperative pain relief, but here we are giving inside the muscle for myofascial pain or iliopsoas. This is a iliopsoas. So means the importance of diagnosing this is you can send to an interventional pain specialist if you diagnose it correctly, and this will get excellent relief with this trigger point injections. Okay, this cannot be done blind, because these muscles are very deep. QL and iliopsoas are deep. Especially iliopsoas is very deep. Okay, so I'll just 2 slides about neck pain, and then we'll go to our case discussion beginning. So neck pain, the pain generators are same only. If it is axial, the disc or bilateral joint. Paramedian, now you already know it is facet. That is why I don't have to teach neck pain again. With upper limb, in low back, it was radiating to the lower limb. Here it is radiating to the upper limb. Think about radiculopathy. The only one extra term is there it was canal stenosis, here it is myelopathy. In myelopathy, there will be neck pain and involvement of upper limb as well as the lower limb. This happens in cervical canal stenosis in elderly patients, similar to lumbar canal stenosis, but it is a cervical level. So not just the upper limb, lower limb will also be involved plus minus bowel bladder disturbance. So that means this anything anyway is a red flag. So you will be sending to a specialist. Neck pain with headache. This is very important. It happens in cervicogenic headache. That is, your pain generator will be in the neck. Okay, but that will get radiated to the headache. So I I don't have time to explain how it will. Usually, the simplest thing is you can ask whether the pain worsens with neck movements. If that is there, it is cervicogenic headache. That is, pain generator is in the neck, either the neck muscle or the neck facet joint, but the patient's pain will be more in the head. So that is cervicogenic headache. So if you don't diagnose, you will be doing an MRI brain instead of an MRI cervical spine. So that is the importance of knowing cervicogenic headache. So, interested participants can read more on the cervicogenic headache. Then neck pain can happen as a part of, widespread pain, inflammatory arthritis, and fibromyalgia. And always rule out red flags. Red flags are same here, there. Then I'll just two things. One is myofascial pain. Again, it is paramedian, right? Paramedian, right? Are you still with me? Is it paramedian pain? Myofascial pain is paramedian, right?
Yeah.
What is the kind of pain? It is
Aching.
Yes.
Yeah, aching, dull aching. And remember, similar to till the knee in the lower limb, it is till the elbow here. That is, this myofascial pain will radiate into the upper limb. Just because your patient says that I am having neck pain, it is radiating to my arm. Don't send the patient for a cervical MRI, because this is very common in cervical myofascial pain and facet, that you will get pain in this aspect, the proximal arm, but not beyond the elbow. And the pathology is here, but this is not, I cannot generalize here, but usually the pain, the muscle pain is here, but it worsens on contralateral flexion. You understood? The pain is here, but it worsens on the opposite side flexion, because this muscle, this damaged muscle gets stretched. Okay. Then these are the location of trigger points. Trapezius is the most commonly affected muscle in neck, and these are the common locations for trapezius trigger points. And the importance of identifying this is trigger point injections gives excellent relief along with stretching exercise. I had a patient from Nagarkoil who was on the verge of suicide, he told, because of neck pain. He's an IT professional. He was not able to do anything because of the neck pain. I also thought this is something, if this is so serious pain, not able, he didn't get any relief with physiotherapy. So I initially thought of some red flags. But on examination, he had trapezius tenderness. So, and no other, red flags were there. So I went ahead with the trapezius trigger point injection. Something as simple as that, a patient who was on the verge of suicide is doing very well now. Actually, 3 months, there was no follow-up from the patient. So I even thought, I don't know whether the patient committed suicide. I didn't get him on phone also. But after 3 months, he came to my OPD telling that this side is okay, please do the same procedure on the opposite side. So that is the importance of identifying these conditions. This is trigger point injection, all of you can do. It is as simple as that, but that can actually, bring a lot of change in that patient's life. Then cervical radicular pain, how does it present? It goes beyond the elbow, radiates beyond the elbow into the fingers. This is a usual dermatomal presentation. C5 sometimes stops above the elbow, but in most of the cases, it goes like this, till the fingers. And here, see, the pathology is in this side, same side flexion. Radicular pain, same side flexion causes pain, whereas the other one, the opposite side flexion. Myofascial pain means usually the opposite side flexion causes pain. So these two are some important tests by which you can, this is Perling test. Those who want to know more about this can read, but this is very important. Just you ask the patient, give some 5 minutes time in the history. The patient will tell you, when I keep my arm like this, my pain gets relieved. You don't have to do anything. You don't have to ask anything. 3 days back also, I had a cervical radicular patient. He was telling me, whenever I keep like this, I get relief. This is shoulder abduction test. Okay. So all these are features of radicular pain. Then facet arthropathy, it can present as unilateral paramedian pain or midline pain. There will be radiation like this into the arm, but not beyond the elbow. And this is very important. In radicular pain and myofascial pain, the pain worsened on flexion. But this is one condition where the pain worsens on extension. Ask the patient to do extension, the pain will worsen. And cervical facet is very common in patients with history of whiplash injury. Okay, So I told about a patient with neck pain, 32-year-old patient with neck pain for 5 years. So that patient, when I actually asked the questions, he was also diagnosed as psychiatric because imaging was normal and he had severe neck pain, not responding to anything. So of course, when he takes analgesics, there will be a little bit of response, but after that, again, the same thing, no response to physiotherapy. So he was labeled as having, psychiatric problem or functional malingering or whatever you call that. So when I asked him, there was a history of car accident, and whiplash injury means like this. Not car accident means he was not hospitalized, anything like that, but there was a history of car accident in which there was sudden hyperextension followed by hyperflexion, whiplash injury. So in such patients, this pesatogenic pain is very common, and the medial branch block of dorsal ramus, that will help the patient. So I did a 2-3, I don't have an RF machine. So I did 3 sittings of this medial branch block, and this patient got around 50% relief. And again, not 100%, but he got around 50-60% relief. And he's on pregabalin also. So I was able to give him some relief so that he can continue his work. He is also an IT professional. Okay. So this you can read, whatever I have told now, when the exacerbating and relieving factors. So this, we come to the end of this presentation. So this is a quote I like very much because I told many times, malingering, often this, if you are not able to identify the pain generator, most of the spine specialists, general physicians, family practitioners, pain and palliative care physicians, many of them, we actually are better, but many others, they call it as functional. So living with chronic pain is hard, but dealing with those who don't understand, be it in your family or be it in your clinic, but those who understand is even more harder. Okay. So thanks for the patient listening, but we are not stopping here. I'm going to ask the first case. So quickly tell me, what is the diagnosis? Anybody can tell.
Facet joint.
Yeah, okay. Good, that I made it simple. That means it is facet joint. Why do you say it is facet?
No, it is not radiating anywhere.
No,
Elderly
first is,
person.
look here, look here.
Elderly person.
Elderly, yes.
64-year-old.
Yeah, elderly. It is diffuse dull aching, no radiation, no neuropathy. Facet can radiate to lower limbs, but not necessary. Okay. Then here.
Yeah, worsening on walking.
Yeah, most of the facet patients will say that when I wake up in the morning, I'll be in severe pain. Okay, with a stiffness for a few minutes. Most of them. Standing, not much problem with walking. Okay. So now this is, I already told you, to altered biomechanics and sensitization. So what should have been the management rather than taking 3 MRIs and referring to multiple psychiatrists and psychologists? What should have been done? You are not getting any clue from the imaging. So what should have been done?
A diagnostic block.
Correct. A diagnostic block should have been done. Maybe this patient is my patient. He has 70-80% relief with diagnostic block and 100% relief with RF. Because I don't have an RF machine. Last month, February 7th exactly, I took this patient to Kottayam and I did RF there along with the senior pain physician from there, and he's having 100% pain relief now after all this history of 5 years going to various psychiatrists, psychologists and all.
How many levels did you have to do for this patient?
I did at the level of L4, L5 and S1. At the level, that means the dorsal ramus of L3, L4 and L5. It was done at the level of L4, L5, S1. And one more thing I did, that is the first time when he came, I gave trigger point injections for this neck and upper back, intrascapular. Okay, that time I gave that also because having severe pain in the upper back and neck also. The next visit, he told that pain is much relieved, but I'm having the lower back pain. Again, how did I reach a diagnosis of facet? Because when I tell like this, it is easy. But when the patient sits in front of me, he says all this is 5 years, I'm having pain here, pain there, pain there. So I can think of fibromyalgia, right? So how did I reach facet is, I asked one question, where it started and how it started. So this patient clearly told me it started in the back. Otherwise, he will not tell you initially, like 2 years, I am having neck pain. Before that, they will tell you that I am having low back, upper back, neck pain, along with stiffness and all. It's like easy to diagnose as fibromyalgia or somatoform pain disorder. But the question that helped me is he told me initially I was having only low back pain. Okay, and now also at this point also, the one that concerns me maximum, even though he says it is similar, the one that concerns me maximum is my low back pain. Then I came back to this 64-year-old, imaging normal. And I told him, I'm not sure of this facet because there is no clinical test to diagnose facet. No, you do 100 MRI CT, you can't diagnose facet. So I told him I will give a diagnostic block and see. So that is how it helped the patient. Okay. Second, what was the diagnosis? We already told it was a case of spondylolisthesis. Yeah, tubercular spine. And generally, these infections, they are referred to as infection in the spine. It can be TB, it can be bacteria, but that is referred to as spondylodiscitis. That term is, so when you see an MRI with spondylodiscitis, written in that, immediately send the patient to a spine surgeon. Because recently only one doctor told me, in the MRI, there are, the MRI, the radiologist is not a clinician. He will write only the diagnosis. So the radiologist has written, what it is, what is the term for degeneration? The common term is something there is no, it's a common term for degeneration. So the general physician thought that it is degeneration. Then only I told him, look at the term. It is spondylodiscitis. It is not spondylolysis, spondylolisthesis, or spondylosis. Yeah, I got that term. Most of the patients say I'm having cervical spondylosis. So this is spondylodiscitis. When that term is there, immediately send the patient to a spine surgeon and never do any intervention. See, whenever I am in doubt, I do a CBC, ESR, CRP, then only I go ahead with an intervention. Even if there is a malignancy, if you are doubtful, you can go ahead with a diagnostic intervention, but don't do, because you will be spreading the infection further. So don't do any interventions. Okay, so I think that's clear. Any doubts you can ask. Okay.
Ma'am,
Yes.
I have one query.
Yeah.
Have you seen any time in patients of myofascial pain syndrome where the one side of the neck or the upper back is more painful or more in spasm than the other side, which has resulted in apparent scoliosis?
Yes.
Or does it improve, or it can lead to the permanent scoliosis?
No, usually postural scoliosis, that is what we call as postural scoliosis or acquired scoliosis, that improve if you treat it early.
If not?
If not, sometimes, especially not in the cervical, I have seen in the lumbar cases, it becomes, kind of sometimes irreversible. The patient will be, even when there is no pain, the patient will, because all these muscles also will go into, permanent damage. They will work with the scoliosis, but usually it is reversible if correctly managed. No other structural problem. If it is just muscles, then usually it is the patient will have, the straightening of spine, everything will come back to normal.
Okay, thank you,
ma'am. Dr. Vineetha, what is your opinion on acupuncture, acupressure, and this Varma therapy?
Acupuncture, actually, honestly speaking, I think I told in the last class also, the Tai Chi has got some evidence in Tai Chi is a newer thing. It has got some evidence in low back pain. If I talk in terms of evidence in osteoarthritis, knee, low back pain, acupuncture and definitely yoga helps. Yoga, meditation, all this helps because there is a science behind that. The stretching, the Surya Namaskaram. There was one pain consultant in our hospital. For any patient with back pain, she just, prescribes Surya Namaskaram. It will help the patient. Because yoga and all these are basically, Surya Namaskaram is just stretching only, low back stretching exercise only. But if you specifically ask about acupuncture, this works through gate control theory of pain, acupuncture, TENS, and all these things. So definitely there are temporary benefits. I have seen my patients getting temporary benefits, but honestly, I don't know about the long-term results, and there is no evidence also to say that about the long. There are, because if one case systematic review says there is evidence, another systematic review will come and say there is no evidence actually. But short-term benefits, of course, I have seen.
But trigger point,
ma'am, what about
trigger point injections? Your experience is good or most of the times.
Okay, I think it was my problem with
My audio.
my audio. Okay.
Okay.
What was the question?
About trigger point injections?
Yes.
Is it done with local anesthetic?
Yes,
or,
yes. No steroid, no steroid. It is done with local anesthetic, and what you inject is not important. How you do is important, because if you are injecting local anesthetic, definitely the effect will get worn off after the 2 hours. Technocan has only 2 hours on set of like duration of action. Bupivacaine maybe 4 hours. So what you are doing is more important. That is needling the muscle. Okay, you can go and read how this trigger point injection helps. There are a lot of theories like needling causes release of local inflammatory mediators, then in manually breaking the nodules, the trigger points. There are so many theories, but what is important is needling, and the importance of giving local anesthesia is patient will tolerate the procedure better.
Okay.
And you have to needle in all the directions of the muscle. For example, trapezius, you take the muscle like this, and then you have to start from one point and needle in all directions. If you just go inside, deposit 2 ml local anesthetic there, this is not going to work for long term. Okay, so how you do it is more important. And when you do it in the neck, one important thing is, if you are doing it paramedian, I don't know whether you are seeing my neck. If in this region, it is fine. But if you are doing more medial, I mean, in the midline, never do it without an ultrasound guidance, because you will inject the drug into dash artery.
Vertebral artery.
Vertebral artery, and 0.5 ml, the patient will go into syncope or seizures. Just 0.5 ml. There is no margin of error. So never attempt an axial or a more medial. Never attempt it blind. I do regularly under ultrasound. It is safe. You are seeing the vessels. But of course here, now in the trapezius, upper trapezius here in the paramedian, you can do, every one of you can do. One structure again, you have to be careful there. Don't go too deep. You will puncture what?
Pleura.
Yeah, pleura. So one pain physician himself developed pneumothorax while his colleague was doing a trapezius trigger point injection. So what I do is I take the muscle in my fingers like this. Whether you are able to see, I don't know. I'm able to, I take the muscle like this, pinch the muscle. So this much is the depth of the muscle. I have an idea how much is the depth, right? Then I do. So if I go like this, especially in thinly built patients, I will puncture the pleura. I will go like this. Okay. So pleura puncture is less common, but vertebral artery is very common. So be careful.
Dr. Khushbu?
Pardon, sir?
Yes, ma'am.
Yeah, Dr. Khushbu, you have raised your hand.
Yes, sir. Ma'am, I want to know about the dry needling.
Pardon?
Are you performing dry needling?
Dry needling. Why I don't perform dry needling is, in my experience, it is very poorly tolerated by the patient. So needling works, whether it is dry needling or wet needling, it works. So I perform only after injecting local anesthetic. In that way, the patient will tolerate the procedure. But definitely dry needling also works in myofascial pain. Okay. Needling works.
Have you used opioids for non-cancer pain?
Definitely. The next class is on that. All those difficult to treat, CRPS, lower limb ischemia. Definitely I have used pancreatitis. But there are certain things to be remembered when you're using for non-cancer that I will be taking in the next class.
Like today's like low backache, like you get a failed back.
No, definitely no. For me, it is a big no, but I know in the Western countries, they give opioids. A lot of low back pain patients are opioid addicts in, opioid, I will not say addicts, it's kind of an iatrogenic dependence. A lot of them are opioid dependents because of their situation. They are not culprits, they cannot be blamed, but I don't. For neck pain and back pain or knee arthritis or all those musculoskeletal conditions, I don't give opioids. I mean strong opioids. Of course, tramadol can be given for a short period of time because there are so many other things we can do. There are so many other things, interventions, and there's so many things we can do. But like the patient I told, facet arthropathy, he got excellent relief with interventions, but all patients will not get excellent relief with interventions also. That is not a, if your patient does not get relief with an intervention, I cannot say I don't have any other option left. I will try to optimize my medical management. I will try other drugs, even gabapentinoids. Many people will differ with me, but textbook itself says that if gabapentin does not work, even then pregabalin may work. If both don't work, amitriptyline may work. I have seen a patient from Pallium only. I think Fulsa knows the patient. One young patient with back pain, imaging, everything normal. Even I don't know the diagnosis except for Bartolotti syndrome, which I didn't tell today. An elongated transverse process that comes in touch with the sacral ala. So other than that, nothing, everything was okay. That patient, we started on duloxetine because already everything else was tried. And on 30 mg BD duloxetine, the patient got very good relief, around 60% relief. So it is not that intervention is the rule. If intervention works very well for some patients, but in other patients, we have to optimize the medical management and physiotherapy, exercises.
Okay, I think we will stop here. It has been more than 2 hours now. And so the importance of this session is that we should at least will be able to understand what is the pain generator. So we can think in that way and remember what are the red flags and yellow flags, so that you will be able to refer the patients also, or you have to do the investigations when it is appropriate. So thank you, Vineetha, for orienting us towards low back pain and neck pain.
Thank you so much.
And yeah, thank you so much. And thank you everybody for your active participation. And we will be sending the module along with the PowerPoint presentation and video links. Thank you. Good
Sir,
night.
one thing, so many people, I was just going through the chat, so many people have written it was so extensive. I understand that it is very extensive, but then the thing is that just to orient you, you don't have to feel bad if you have not taken all of this. But some things I have told again and again, like red flags, you register that. You should know when if you don't identify the pain generator, that is fine. But if you know when to refer, when to identify a red flag or yellow flag, that is enough. That was the whole point of this class. But because we have so many other chronic pain syndromes in the other classes, neuropathic pain and joint pains, I had taken low back as a single class. And at least some of the pain physicians in this, they may be getting low back patients. So they will have to identify the pain generator. That is why I took it, examination history in all detail. But everyone doesn't have to take all this home. Take home is only to find out, when to refer, when to take an MRI, and how to guide the patients correctly. That's it. You don't have to identify the pain generator all the time.
But I think there is another message also. Even in cancer patients, they may have pain not only because of cancer. There are many other problems that can cause pain. So that's also included in this session. So thank you, Vineetha.
Okay, sir.
Yeah. So good night, everybody.
Thank you, Dr. Vineetha. See you in the next session. Yeah, I was personally, I was thinking about becoming Dr. Vineetha's patient actually, because whatever she was saying, I was also experiencing this low back pain and this whiplash accident, especially. I could connect with that. So thank you so much. Without
Yeah,
much
I am
ado,
happy that even being a non-medico, you grabbed this much from my presentation, because whiplash is very important. These patients are considered as psychiatric because just because they don't know how whiplash is associated with mesotogenic pain. So that is what entire intention only. My intention was only that, just to give some keywords. So don't
Sripriya
feel
is
bad.
a doctor, Vineetha.
Huh? Oh yeah.
Sripriya is a doctor.
Okay,
Because
then it's fine.
she has
Actually,
had many presentations. We might have had only few, but she's hearing it for last 2 years. So
Okay.
she has now become a doctor.
yes,
Okay,
I'm
okay.
just waiting for the certificate to be issued from Dr. Sunil.
So
So
it is
that I can
like
start
just
the
like we
practice.
talked acquired scoliosis, this is an acquired medico here. Now we have an acquired medico here.
So thank
That's
you
nice.
everyone. See you in the next session. Till then, everyone take care. Bye bye.
Yeah, yeah. Thank
Right.
you, sir. Thank you, everyone.